Good evening, everyone, and welcome to HIC Clinical Conference for Thursday, December 9, 2021. This is continuation of our Masters of Medicine Clinical Conversations. We have been doing this by Zoom meetings since the onset of COVID. Today, I'm very honored and privileged to welcome my friend, Mr. Dr. Alon Eisen. Alon is joining us all the way from Israel. It's pretty late down there. It's about 11 p.m. So it's a major sacrifice for him to join, and we appreciate it. Alon is a senior cardiologist at Rabin Medical Center, affiliated with Sackler Faculty of Medicine at University of Tel Aviv. He is currently Deputy Director of the Cardiovascular Division in Rabin Medical Center, and he's the head of Clinical Cardiology Research Unit. He also heads the Post-Myocardial Infarction Clinic. He serves as the Secretary of the Working Group on Cardiovascular Pharmacotherapy of the Israel Heart Society. Professor Eisen completed his fellowship in the TIMI study group at Brigham and Women's Hospital and Harvard Medical School in Boston. He is currently an associate professor in cardiology at Tel Aviv University. His main research interests include secondary prevention after acute coronary syndrome, novel pharmacotherapies, and atherosclerotic risk factors. Alon will be speaking to us today about acute coronary syndrome, and he will have a lot to share, and then we are ready and eager to listen. Alon, over to you.
Thank you very much, Ernest, for this kind of introduction. Good afternoon, everyone. It's actually a pleasure and privilege to speak today at your Congress. So thank you very much for the invitation. Let me just share my screen. So my talk today will be about the management of high-risk patients after an ACS. And the question I will try to answer is, can we do better? This is my disclosures, none of which is relevant to the talk today. So this is the outline of my talk. I'll give a brief introduction and then speak about different patients with different risk. I'll speak about gender, polyvascular disease, and then about secondary prevention measures, which is part of my work, everyday work, regarding lipids, antithrombotics, diabetes, inflammation, and some future aspects and summary. I will give you some data I think is interesting from our work in Israel. And I'll start with a brief introduction. Of course, the topic today of the talk is acute coronary syndrome, either ST elevation or non-ST elevation ACS. And this is data from the ACS registry in Israel. The ACS is a national registry, a biannual registry, including all cardiology departments in Israel. And you can see here the 30-day death of patients with ACS during the last 2 decades. And as you can see, from 2000, we actually have done better. From a rate, a 30-day death rate of about 10% in average, in the year 2000, in the year 2016, it's about 3.5%. Again, lower in males and higher in females, and as we all know. But I think this is quite nice that rates have decreased. And also in 30-day MACE regarding re-MI, stroke, and death, the rates have decreased during the years. And again, I think it makes sense that what we did, what we have done, what we have implemented actually worked. But still, I think there are some data that is concerning. And this is from the ACS registry in Israel, 2016, showing that among patients who are admitted with an ST elevation MI, for example, about a quarter had a prior ACS. And from patients who are admitted with a non-ST elevation ACS, about half of patients were admitted before with an ACS, meaning that it's their recurrent event. And this is quite concerning. I found this data, and my talk will be regarding, of course, this issue. We know that the risk recurrent MI or recurrent cardiovascular event after an MI is not linear, and it does not go away after the first year, of course. It goes up in a linear fashion through many years in a lifetime. From the prospect study, we have learned that if we thought in the past to treat the stent, or there is something that is a vulnerable stent or so lesion, we know today that we're speaking about the vulnerable patient. We treat patients. We know that recurrent events are likely to originate from new atherosclerotic plaques as they are from the initial culprit lesion. And overall, the goals of treatment now in secondary prevention is summarized nicely in this figure, showing that lifestyle modifications, including medications that deal with lipoproteins, inflammation, metabolism, platelets, and coagulation, we all have to take these into account when treating our high-risk patients. Now, that's for the introduction. I'll speak a bit about different patients with different risk. And I think overall, when you look at, this is from the chronic coronary syndrome guidelines, the European guidelines a few years ago, we know that patients with chronic coronary syndrome have different prognosis. There are those in the green line, which can have a revascularization and then during lifetime do not have recurrent events. And there are those in red, for example, that their prognosis, their cardiac risk, meaning death and MI, are high. They have increased, they have recurrent events with revascularization, recurrent ACS, and of course their prognosis is poor. Let's take, for example, two patients, trying to do it in a figure. On the left, you can see Lowy. He's a 42-year-old male who is a smoker. He doesn't have any cardiac coronary artery disease risk factors other than that. He's admitted with a STEMI, with one vessel coronary artery disease, and he undergoes primary PCI to his RCA. So his short-term risk is quite low, or short and long-term risk is quite low. Again, he's young. If he will be stabilized in terms of his risk factors, if they will be controlled in a nice fashion. So overall, his lifetime risk is quite low. Heidi, on the other hand, is a 78-year-old female with diabetes, hypertension. She had a prior stroke, mild CKD, and she had a prior non-ST elevation MI, and she's admitted with non-ST elevation MI now with two vessel coronary artery disease and undergoes PCI to RCA and LAD. So her risk, short-term risk, is quite high, and her long-term risk is also quite high. Asking who will be treated with guidelines medical therapy more in a more robust way, of course, Lowy will undergo more PCI and will be treated with more guideline-directed medical therapies. And trying to assess the risk after an acute coronary syndrome is quite difficult, I believe. But I do find the TIMI risk score for secondary prevention quite useful. It is a clinical risk score, which you are probably familiar with, that includes 9 risk indicators listed on the left, including heart failure, hypertension, older age, diabetes, prior stroke, prior CABG, PAD, CKD, eGFR below 60, and current smoking. And the more criterions you have, the more indicators you have, the higher the risk. Such that if you have 0 or 1 indicators from this list after an ACS, you are at low risk for recurrent events. If you have 2 risk, so you're at intermediate risk. And if you have 3 or above, you are at high risk. And this risk score was validated in quite a lot of trials now. And I'll just show some data we have worked on from several studies. This is from the IMPROVE trial, just to recall the benefit of adding ezetimibe to statin therapy in patients with ACS. And we examined in the IMPROVE trial the benefits from adding ezetimibe to statin therapy in patients with prior coronary artery bypass graft surgery who are admitted now with an ACS. This is a very high risk group with a high number of recurrent events. Just to go back, the IMPROVE trial was a randomized control trial, which examined ezetimibe and simvastatin compared to simvastatin alone in patients with ACS, and showed that ezetimibe reduced overall the primary endpoint in a modest way by about 6%. If we look at the 10% of patients in the improvement trial that had a prior CABG and now are admitted with an ACS, we see that overall the rates of their events are quite high. You can see here the primary endpoint reaching about 55% compared to those who did not undergo a prior CABG before that. Of course, the effect of ezetimibe in these patients was the same as for the other patients. But if you look at the primary endpoint, it is nicely shown in red. Patients with prior CABG benefit more from ezetimibe treatment added to simvastatin with an absolute risk reduction of almost 9%, a number needed to treat of 11, with a relative risk reduction of about 20%. So this is quite robust as compared to the other patients who are considered at a lower risk. They benefit less from ezetimibe. And if we look at patients with no prior CABG, those who did not undergo any CABG before that, you can see that those who have a higher TIMI risk score on the right, they had an absolute risk difference, an absolute risk reduction more robust or higher than the other groups, meaning that lowering LDL to a lesser extent in these patients, there is an absolute risk reduction, a higher absolute risk reduction. And following this work, we've done some other works examining the increased benefit of treatment in patients with different TIMI risk score for secondary prevention. Again, this is from the ACS registry, the Israel registry. In all patients with an ACS, we categorize the patients to 3 groups: low risk, intermediate risk, and high risk, according again to the TIMI risk score for secondary prevention. Here you can see the distribution of all patients, almost 7,000 patients. And as you can see, patients who were at high risk were of course older, with a median age of about 70. There were more female there. They have comorbidities such that 70% has diabetes, for example. About a half had a prior MI, a fifth prior CABG, meaning a very high-risk group. And if we look at why they were admitted with the ACS, most of them were admitted with a non-ST elevation MI. They underwent more multi-vessel PCI. They had a higher Gray score and, of course, a higher KILIP class score. But interestingly, looking at more than a decade, or almost a decade long, you can see that the prognosis has improved. But if looking at the low risk and intermediate risk in green and yellow, you can see that their prognosis has not changed during the last decade. The prognosis has improved in these high-risk patients, only in the high-risk patients in red, from 21% 30-day MACE to less than 10%. So this is quite encouraging that the higher the risk, they benefit more during the years from the advanced medications and, of course, PCI that were given. Looking at the extreme now in a different work, looking at just in high-risk patients, is there a graded association in the particularly high-risk patients? We also did this work, which only examined patients who have a TIMI risk score of 3 and above, and we categorize them to patients who are at high risk, very high risk, or extremely high risk. Are these patients? So extremely high risk, for example, the median age is almost 80 years old. The majority had hypertension, diabetes, PAD, 50%, chronic kidney disease, more than 50%. Almost half had a prior CABG, more than 2/3 had a prior MI, heart failure in about half. So this is the very extreme patient with acute coronary syndrome, and you can see the characteristics of it on the right. So they have a more complex acute coronary syndrome. But if we look again on the right, which treatment have they received? So of course, patients who are extremely high risk, the elderly, those with comorbidities, receive less medication, less guideline recommended therapy in terms of statins, in terms of dual antiplatelet therapy, etc. However, And looking on the left, look at the 30-day MACE, they have a very high 30-day MACE of about 20% and a 1-year mortality of about 30%. Now, what happened during time, and interestingly, again, in all risk strata, prognosis has improved. 30-day MACE has improved in all risk strata, in extremely high risk, particularly from 26% to 60% 30-day MACE. However, there is probably a glass ceiling for mortality in this elderly and comorbid population. So their 1-year mortality a decade ago or now have not changed, and it's about 30%. So it's very high mortality rate. You can see here the KM curves of that. So overall, the take-home messages from these works, I think, is that among high-risk ACS patients, although treatment significantly improved over the last 2 decades, the prognosis has improved as well. And thus, guideline-directed medical therapy should not be denied this very high-risk spectrum of patients after an ACS. So this is a bit about different patients with different risk and how to assess the risk. And a specific subgroup that I'm interested in is of course, gender. Women are have been traditionally undertreated, underdiagnosed with an ACS, but with, I think, good education and public education and knowledge, the international societies, of course, recommend the treatment of men and women with ACS the same. So both gender must be managed in a similar fashion. And we are familiar today, of course, with more traditional risk factors or other risk factors than the traditional ones on the right, which are specific to women, and thus we can address this more appropriately in women. Of course, we're thinking about pregnancy complications, we're speaking about autoimmune disease, depression, of breast cancer treatment. So all of these are not traditional risk factors we're all familiar now. We also know, I think, more today about other manifestations rather than obstructive coronary artery disease that we usually speak about in acute coronary syndrome. We're speaking about microvascular coronary disease, which is more common in women. And this normal coronary angiogram is part of an ACS in women. As we all know, MINOCA, MI with non-obstructive coronary arteries. So I think today we diagnose more MINOCAs than in the past. We are very familiar with this. We know that ACS should not only be obstructive coronary artery disease, but we also have measures, we have tools today to identify myocardial infarction with non-obstructive coronary arteries, performing, for example, a cardiac MRI to each patient. And in my department, we do a cardiac MRI to each patient with arrives with an ACS or possible ACS, but still his coronary angiography does not show obstructive lesions. So MRI is a wonderful tool. Why is it important? It is important to give precise treatment if it's an MI, to give the same DAP, the same statin, same risk factor modification. So it's important to diagnose first. And of course, again, imaging is, I think, a very important part in our clinical practice today in this sense. Looking at women with acute coronary syndrome, just showing data again from the ACS registry in Israel during the last 2 decades. So women, only women is shown here, are admitted more and more with non-ST elevation ACS. And this is something which is also shown, of course, in men, less STEMI, more non-ST elevation ACS. And this is a slide showing the management of women during the last 2 decades, going up from PCI from 40% to almost 70% nowadays. And just looking at the primary PCI in STEMI from 50% going up to 95% of women with ST elevation MI. The radial axis have, of course, changed our PCI technique and improved morbidity and mortality. And currently, it's in the rate of women in women, it's about 70%, at least in Israel. 30-day MACE of women has decreased also in a STEMI and non-ST elevation ACS. But still, 1-year mortality decreased only in women with ST elevation MI, but not decreased or did not reach statistical significance in patients in women with non-ST elevation ACS. This is just a word about gender, and looking over another high-risk group is the group with polyvascular disease. So we know that polyvascular disease is a condition, of course, that when 2 is not better than 1, involving other atherosclerotic beds, which I found this population quite interesting in terms of their very high risk. Looking here, data from the IMPROVE trial showing that patients who have not just coronary artery disease, but also have coronary artery disease and PAD, or peripheral artery disease, for example, lower extremity, or those with stroke or TIA, they have higher, of course, cardiovascular complication. And we know today that the medication we use, or some of the medication we use, do have an increased benefit or an added benefit in this high-risk population. This is data from the Fourier study, the PAD sub-study, showing that patients who were treated with PCSK9 inhibitor, the evolocumab, those with PAD as compared to those with no PAD had a higher absolute risk reduction with evolocumab. This is data from the Pegasus TB54, and again showing the same concept that higher the risk, the more you benefit from increased DAPT. In this case, prolonged DAPT with ticagrelor, again, in patients with PAD as compared to patients with no PAD. And of course, we know today that probably these patients, they might benefit not just from dual antiplatelet therapy, but also from the dual pathway concept from with aspirin and rivaroxaban with a vascular dose, which I will speak about in a few minutes. Patients with PAD, peripheral arterial disease, again, they are the most complex patient I think we have in terms of vascular lesions. They are also prone to bleeding and vascular complication. And I think the vascular approach, which we are now doing in most instances, have changed dramatically and impacted these patients, particularly these high-risk patients, decreasing, of course, morbidity and mortality, and not less important, decreasing bleeding. So with this, I'll just give a few words about the some some secondary prevention measures we all now use, and you all are probably familiar with that. Just give a short and brief overview of these. So looking at lipids, of course, we know today that the concept of lower is better for LDL cholesterol is probably true. I believe that the lowest is best particularly for patients who are the highest risk, as I showed before. Again, we have data from the IMPROVE with ezetimibe. We have now data from robust data for PCSK9 inhibitors with monoclonal antibodies, evolocumab and alirocumab. Of course, from the Fourier study in patients with established atherosclerotic cardiovascular disease, which are stable, and also from the Odyssey outcome study, which included mainly patients who are post ACS. And again, I think it's quite quite promising that we have medication today that reduce the LDL cholesterol on top of statins in about more than 50%. This is from the Fourier study, and reducing the relative risk reduction in about 15%. And you can say that this is quite modest, but I believe it's robust, it's high. And again, we have to remember that statin LDL lowering, it probably takes time until the effect of lowering events. So this is 50% for in 3 years, but I believe it's much higher in the long run. This is data from the Odyssey outcomes that you're probably all familiar with, showing that patients who might benefit the most from alirocumab treatment is those who have a baseline risk or baseline LDL level, which is higher of 100 milligram per deciliter or above, meaning again, the highest the risk, the more you benefit from PCSK9. And this is new data from the Odyssey outcomes trial showing lipoprotein A analysis, showing that those who have a higher lipoprotein A, not just LDL, but also lipoprotein A, might benefit more from alirocumab treatment as compared to those who have lower baseline levels of lipoprotein A. And at my department, the majority of patients who are admitted with an ACS nowadays, we also measure lipoprotein A just to stratify their risk and perhaps tailor therapy to this increased risk. We also know today that, similar to statins, PCSK9 inhibitors probably have pleiotropic effects, meaning that they don't just lower LDL cholesterol, they influence at the level of the platelet, of the level of the endothelium, of the macrophage, of the vascular smooth muscle, and more. And my team has also contributed to the literature showing that in patients who are treated with PCSK9 inhibitors, the level of endothelial progenitor cells, which are cells that are derived from the bone marrow when there is endothelial injury, the levels after PCSK9 inhibitors injection increase, and the function of these cells also increase. So this could be another pleiotropic mechanism of PCSK9 inhibitors. Of course, we all are familiar with the guidelines today, meaning that to start with statins and ezetimibe, and then PCSK9 inhibitor if target is not reached. But I have to say that if we used to wait for 6 to 8 weeks in the past to see if the patient is stabilized, we now you guys hear me?
Okay.
Okay. Yeah.
Okay. Yeah. You're good.
Okay. So sorry. So I was just saying that the timelines for increasing treatment for LDL cholesterol reduction has decreased, and now I think it's good to have an LDL cholesterol measurement after an ACS about few weeks, like 4 weeks after an ACS, and if the target is not reached, it's you have to escalate treatment. And if we look at the goals, again, the goals, as we all are familiar, is reaching very low levels of LDL cholesterol. And in the very high-risk patients, as I mentioned before, I even tend to lower LDL cholesterol even below 55, and even around the 40s, the 30 or 40s. Of course, triglycerides are also a target for treatment nowadays after the REDUCE-IT trial that we all are familiar with, examining the Vascepa, an omega-3 treatment with high-dose omega-3, which showed in the REDUCE-IT trial that treatment with icosapent as compared to placebo in patients with increased triglyceride lowered eventually events for the first time, actually. And I think it's quite a promising treatment as well. And of course, we have the small interfering RNA inclisiran, which is already here at least approved. And I think it's quite promising, not just because of the new technique, but also that it might increase the adherence of the patients, giving a shot, an LDL cholesterol lowering injection every 3 to 6 months. So I think it's quite promising as well. Antithrombotics is, of course, another field of major research. Dual antiplatelet, which is of course, our mainstone for treatment of ACS. But we all know today that how long to adapt is a question, and it's different from a patient to patient, and it has to be tailored for each patient according to its risk. And its risk is based on patient-related factors. His risk is related to the anatomy and the stent-related factors as well. And we know from the DAPT study that patients who had an ACS might benefit from prolonged dual antiplatelet, of course, with aspirin and clopidogrel, and also from the Pegasus 54, patients who had an MI might benefit from prolonged dual antiplatelet treatment with ticagrelor as compared to aspirin alone. And what I mentioned before is, of course, the not just the dual antiplatelet concept, but prolonged antithrombotics in a patient who are at very high risk could be also by the dual pathway, meaning that we are inhibiting not just the platelet, but also, of course, the coagulation cascade by giving rivaroxaban in a vascular in a low dose. And this is based on the COMPASS study. You probably all know, I will not go over through that, but just mentioning that as compared to aspirin, rivaroxaban plus aspirin in the long term in patients who have stable atherosclerotic disease, lowered the incidence of the rate of the cardiovascular death, stroke, and MI. Of course, in the price of major bleeding, but still the net benefit of this treatment is favorable for the dual pathway concept. And again, patients who are at increased risk, such as those, for example, with peripheral arterial disease, as shown here, might benefit even more from treatment with an absolute risk reduction, with a greater absolute risk reduction. And at least in Israel, the dual pathway concept, aspirin plus rivaroxaban, is approved in patients who have coronary artery disease with peripheral arterial disease, so a very high risk group. Of course, in diabetes, we also have very good news from recent years. You all are familiar probably with the coronary angio of a typical patient with diabetes with more extensive and diffuse coronary artery disease, the fast progression of atherosclerosis. And of course, these patients have worse prognosis in terms of short and long-term prognosis, more cardiovascular death, and more heart failure. And I think it's needless to say in this forum that we have now the GLP-1 receptor agonist and the SGLT2 inhibitors, which actually change all the paradigm in treating diabetes, meaning that we treat the patient and the risk of the patient and not just his sugar level and his hemoglobin A1C. And this is the method, of course, all the cardiovascular outcome trials of the GLP-1 receptor agonist showing a reduction mainly in MACE, some reduced MI, some reduced stroke, and of course, in the leader trial, liraglutide, which reduced cardiovascular death. These are the modes of action of GLP-1, and I found this therapy very promising. The majority, or at least many patients, or many of my patients after an ACS, which are eligible, receive GLP-1 receptor agonists. Of course, SGLT2 inhibitors are also in use. This is from the EMPA-REG trial with empagliflozin. And I think, again, we all know now that SGLT2 inhibitors, again, not just work on the pump, on the muscle, they work on the pipes, meaning on the vascular, reducing MACE, and also on the filter, such that they reduce also kidney injury, and they have beneficial effects on the kidney. And I think we all understand better today the connection between diabetes and heart failure, many thanks to the SGLT2 inhibitors and to other group of medications, but we do understand it better. And again, SGLT2 inhibitors, of course, are now indicated for reducing heart failure in these patients. So just looking forward, of course, that patients who are diabetes, who are at high risk after an ACS, I think should benefit and might benefit from SGLT2 inhibitors. And many of my patients, at least, are treated both with SGLT2 inhibitors and GLP-1 receptor agonists. Regarding inflammation, I think inflammation is quite a fascinating topic in terms of atherosclerotic and recurrent cardiovascular events. We all know the association between atherosclerosis and inflammation. They're, of course, related one to each other. And there are these patients who have the residual inflammatory risk, meaning that their LDL is quite low, they don't have other risk factors, but still they are admitted with recurrent events. And in terms of inflammatory risk, I think the Novo ATLAS trial, I think, gave this a great definition and examining the canakinumab, a human monoclonal antibody against interleukin-1 beta, and showing that in patients with atherosclerotic disease, when you treat with canakinumab, you don't actually influence the lipid profile. You do decrease the CRP levels, decrease inflammation. But the great question was whether decreasing CRP will improve or will change or will impact cardiovascular events. And indeed, in the CANTOS trial, there was a nice reduction in cardiovascular events, in MACE. And I think this just opened the way, of course, or led the way to many trials with anti-inflammatory drugs in patients with ACS, including methotrexate, for example, which was a negative trial, but also with colchicine, which is, I think, a promising, very cheap and very old medication that we will be used in the near future in terms of ACS and chronic coronary syndrome. And we have now robust data of randomized control trials with colchicine once daily to reduce MI, stroke, and coronary revasc. So just to summarize and look at some future aspects, well, if I look at the field of ACS and the high-risk patients after an ACS, I believe the future will include a lot of genetics. So we have some genetic data today regarding ACS, but I think we know less how to use it. For example, genomic risk score, how do we interrogate it into the clinical risk profile? How do we use it in clinical practice? So I think it's still a matter of research. In terms of the microbiome, I think we'll have an impact in the future. And we have a national project in Israel with Rabin Medical Center and the Weizmann Institute of Science, looking at factors or looking at the microbiome in patients with an ACS and trying to characterize it and examine whether patients who have different microbiome have different risk for recurrent events. I think a lot of research is still needed in the field of out of hospital or sudden cardiac arrest. We still, I believe, do not know exactly who will benefit most from defibrillators, from an ICD. Of course, we know the regular things such as ejection fraction, etc. But still, I think this should be more precise to try to identify patients who are more prone to ventricular arrhythmias. Of course, we have today several measures to decrease the risk, whether it's regular ICD, subcutaneous ICD, or a wearable defibrillator that we use in several instances. So this field, I think, deserves further research. Cardiac imaging is a field that will, I think, will increase more and more in terms of examining particularly differential diagnosis of acute coronary syndrome, in particular MI with non-obstructive coronary artery disease. And not just cardiac imaging, but also looking at specific pathologies that cause an ACS. So we currently treat most pathologies the same, whether it's plaque rupture, plaque erosion, etc. I believe in the future we'll have more tools to treat pathology in a particular way, in a specific way, rather than a broad treatment to all. And this will include also intravascular imaging we use today, such as OCT and IVUS. I believe we'll have it more and more in order to characterize better an acute coronary syndrome and try to tailor a specific therapy. We have new therapies on the horizon, not just new therapies, but also perhaps new indications. For example, we might give in the future PCSK9 or potent LDL cholesterol lowering therapies during the acute event. And this is on the left from the EVOPAX study, which examined evolocumab during the acute event, showing that LDL cholesterol reduction was robust, but still we need more clinical data for that. On the right, of course, inclisiran, and we're still looking for clinical data from phase 3 studies. And finally, this is my last slide. I was privileged and I had the honor to be under the mentorship of Dr. Eugene Braunwald, who is the father of modern cardiology, for 2 years. And from this paper, we wrote about looking at the ACS, the acute coronary syndrome, and trying to foresee the future. And what Dr. Braunwald wrote is that he thinks that the most important change in the management of patients with ACS is likely to come from changing our current population-based approach, which we do now, to a more precise, personalized approach. And in this effort, we might, cardiologists, take an example from the oncologist notebook, which actually do that in practice nowadays. So with this, I'd like to thank you all for listening. Thank you very much, Ernest, for the invitation, and shalom from Israel.
Thank you very much, Alon, for this very elaborate and enlightening discussion on current therapies for ACS. I think you kind of like brought a lot of points forward that I'm sure a lot of people will want to have questions. And just let me briefly say before we go into that as standard in these meetings, we will take questions from the audience. If you have any question, please send it to me directly on the chat, and then I will address questions as they come. But I'm going to kick it off with a few of my own questions to Alon, and I have a lot of questions. As usual with these topics, whenever we talk about these, there's always more questions than answers. But there's something that is intriguing, Alon. In your presentation, you make the point that about 30-day MES in elderly population that hasn't really changed much over the years. And then we also have the 1 year MES in women with non-ST segment elevation MI, which remains pretty flat. What are we doing wrong?
I think if we knew that, we'd probably fix that. And but yeah, I think it's a very good question. We still have, I think, gaps in treatment. First, specific population, for example, women with non-ST elevation ACS are elderly. They have more comorbidities. And again, we examined just 1 year mortality, all-cause mortality. So perhaps there is a glass ceiling for that. But I believe still that although we improved in terms of guideline-directed medical therapies and more PCI, I believe we still do not have specific measures for specific conditions. For example, MINOCA, we don't really know the treatment for MINOCA, right? We treat it as a regular MI. We give DAPT, we give statins, but whether it really improves prognosis, we don't have really data for that. We have data from registries, but we don't have randomized control trials for that. So I believe we still have gaps in knowledge, and I agree.
And then talking about DAPT, you also did mention that in Israel, DAPT is approved for treatment of patients with combined ACS and PAD. What's your approach to PAD patients, with acute coronary syndrome? Do you routinely evaluate patients for PAD when they present with ACS to determine that of course, I believe that this is a systemic problem. So one and the other naturally will not be surprising to coexist. Do you routinely evaluate patients, for PAD when they show up? If you don't, why don't you? If you do,
Yeah.
why do you do? What do you recommend for others?
Yeah, it's a great question. Well, at least in Israel, we don't routinely, during the acute event, we don't routinely screen patients for peripheral artery disease. I think the main reason for that is, of course, cost, etc. But again, if you treat them and you give them treatment for one vascular bed, so this treatment is probably helpful for another vascular bed without even knowing if it's there or not. During follow-up, at least in my clinic, I had the post-MI clinic, and I do screen patients for peripheral arterial disease, particularly in patients with symptoms. I do that, first of all, if there are symptoms, of course, to treat the symptoms, but also to get a sense of how much to escalate treatment if I know there is also PAD. So for example, if I want an LDL cholesterol goal of below 55 milligram per deciliter in all patients, so in these patients with PAD, I will go for less, for example. I will better control them with anti-diabetic medications, etc.
Okay, I have another question, sent to me by, so what is the typical patient with ACS that should be considered for GLP-1 receptor agonist and SGLT2 inhibitor therapy post-ACS?
Who is the typical patient?
Right.
All of them?
You think all patients post-ACS should be on GLP agonists and the SGLT2 inhibitor?
Well, first for GLP-1 receptor agonist, I think first all data is for patients with diabetes type 2.
Okay, that's where I'm going.
So for diabetes type 2. So for diabetes type 1, we don't have really data for that, and we don't use GLP-1 receptor agonist for it. We don't use it for patients with advanced chronic kidney disease, or of course in patients who have contraindications, such as those with pancreatitis, medullary thyroid carcinoma, etc. But for me, the majority of patients who are eligible with type 2 diabetes, particularly those who are obese, with a BMI above 28 or even above 25, I think they are eligible. For SGLT2 inhibitors, this is quite interesting. For now, it's again patient with diabetes, but I think in the future, and again, there are ongoing studies for that, we might treat patients who are post-MI, who are in an increased risk for heart failure, that do not have diabetes. And these are something, it's in research for now. For example, the IMPACT MI study in patients with NMI with a large territory who are not necessarily diabetes.
Yeah. So yeah, I think that's an interesting concept, and I personally also think that we're heading into that direction. Where patients at risk for heart failure will probably be considered for GLT2 inhibitor therapy post ACS. Now, but there is another area of it that I've always wondered about. Perhaps you can, talk about it. Now, the GLP-1 receptor agonists. Would you think that there will, in the future or at any time, be a role for that in morbidly obese patients with ACS but no diabetes?
Yeah, but no diabetes?
Yeah.
Well, GLP-1 receptor agonists, we know we have studied for that, not just treatment for diabetes, but also for weight loss. Whether we'll prescribe these medications just for weight loss, I think we're going to this direction. I don't know what's the situation in Jamaica, but in Israel, it's quite fashionable to come to the primary physician nowadays and ask for the semaglutide in terms of weight loss, for weight loss indication, not for diabetes. Still, it's not really approved in the health basket. It's not. But I believe we'll have more and more data for that, just for the weight loss indication. And when you look at my ACS or your ACS patient who is obese, you want him to lose weight, and why not? Of course, we know it's beneficial.
Well, remember, we're in an island, so we don't have obesity. We don't think we do. We're constantly at the beach, so we don't have to worry. I have an interesting question from Dr. Mezue from your old, stomping ground area from MGH. Kene has a question. He says, thank you very much for a fantastic overview. His question is, do you check lipoprotein A on all ACS patients? If not, when do you choose to check it? And how do you address the risk? I think there is some evidence that PCSK9 inhibitors might help, and some new evidence that CTEPI might also be helpful. When do you check? Do you check for LPA? And if not, why not? If you do, when do you check, and how do you address the risk?
Yes, so that's a great question, and I think in the last year or so we started to check LPA in the majority of patients who are admitted with an ACS, either during hospitalization or afterwards when they come to the clinic, about 4 to 6 weeks after the hospital discharge. We do that because of several aspects. First, to examine the risk. Second, there are ongoing trials for LPA reduction. The Horizon AMI trial, for example, is one trial that we are involved in. A specific treatment for LPA reduction. And as mentioned, currently, PCSK9 inhibitors, the monoclonal antibodies, is the only treatment that I know that lowers LPA. And I think data from PCSK9 inhibitors are quite promising. Now, who to check? If you check not to all patients, who yes to check? I think I will go for the younger patients who have a lifetime risk. I will go, I think, for those who are admitted with an ACS, which we cannot identify a particular risk factor. So in these patients, I would probably go and check on a regular basis. Again, only one time per lifetime.
Okay, great. Let me invite, I think Dr. Tolerate has I saw a question and a comment. Tolerate is cardiologist at the Heart Institute of the Caribbean in Jamaica. So, Edwin, you are on.
Hello, can you hear me?
Yeah, but we can't see you. It'd be nice to see your face.
I'm trying to figure it out. I'm on the phone. But Dr. Eisen, I enjoyed the presentation. It was really good. Let me first say Baruch haba. So welcome.
Thank you very much.
So anyway, I'm glad you mentioned residual inflammatory risk, because that seems to be the much bigger challenge. Because with PCSK9 inhibitors on top of statins, we sort of conquering residual cholesterol risk. But with inflammatory risk, that's where the big challenge lies. And where do you think the dust is going to settle? Is it going to settle with colchicine? What do you think about methotrexate, interleukin-1 or interleukin-2 inhibitors? Because that's, sort of trying to, your crystal ball, I would appreciate just hearing where you think that's going to go.
Well, I think thanks for the question. I think again, it's a very interesting field, and I think currently it's an unmet need. For example, I have few patients, young patients with recurrent cardiovascular events, and the common what's common in this patient for all patients is that they have either psoriatic arthritis or other autoimmune disease. And at first, I think we have to, as cardiologists, be in a close relation and be in touch with their physicians, rheumatologists, or others who deal with the, if it's known, with the specific disease. But in the majority of cases, it's not really known. It's not really a disease. It's just an increased inflammatory state. I believe that colchicine is the new kid in town that we will use due to its first cost, quite low side effects, and its beneficial effects. So I believe due to the quite robust data we have in recent years, I believe it will be mentioned in the future guidelines. Whether there will be other agents, I believe so. I don't think canakinumab, and of course we know it's not going forward due to its cost and adverse events. But as for now, colchicine, and I have some patients which receive colchicine for this indication. Again, it's a very cheap drug, and I tend to use it. It's a low dose. It's once a day, so the side effects are very minimal. So for now, this is the treatment.
So I think this is a good segue to another question that was sent to me, which is similar to, the whole inflammatory cascade, question that has been driving everybody crazy over time. So intuitively, think, inflammation is a major part of it. Dr. Barr has been preaching inflammation for many years as the root cause of everything. We know Cantus was a positive trial in terms of MACE. Calcott was positive, Cantus was positive, but some of them, quite a good number of other studies, big and small, have not panned out, the way we thought in anti-inflammatory, response. So, we are discussing about whether this will probably get in the guidelines in the, coming years ahead. Do we even know what we're, thinking about? Is it that, one of the things with the inflammatory process is very, very, how do you say it? It's not a simple pathway. It's a very complex pathway. Is it that targeted anti-inflammatory response is the answer or not the answer? Or is it a general anti-inflammatory, response is the approach? So we know.
Yeah, so I think that's the issue. As for many other drugs, currently it's very broad. It's something in general. And whether it targets the exact inflammatory process and the unique process of a patient, we don't really know. Currently, this is what we have, and I believe because it's so broad, in some trials it was positive, in some trials it was not. The future, again, not just in anti-inflammatory drugs, I believe will be more specific, targeting the specific pathway, the specific point at the inflammatory, algorithm, and try to inhibit there, and not like a regular broad mechanism.
I have another question from Dr. Noel Crooks. Dr. Crooks is also a cardiologist here in Jamaica. He has, and I read his question, I have seen a few unusual cases of polycythemia and ACS. Your thoughts on management after and also any smoking cessation protocols for risk reduction post ACS. He would like to know. First,
again, polycythemia and smoking cessation?
Polycythemia and ACS. Seeing a number of patients with unusual cases of polycythemia and ACS. I guess the relationship now is polycythemia and smoking. And what's the general approach to this and smoking cessation protocols for these types of patients?
Yeah. So for polycythemia, and again, for specific, I think, hematologic conditions, which I believe are pro-coagulant or pro-thrombotic, I usually work with the hematologic department in our institute. For example, in cases in which specific young patients, for example, do not have risk factors other than either polycythemia or I suspect of other hematologic condition. So I send them for, hematologic just screening, looking at specific conditions such as antiphospholipid, etc. Specific for polycythemia, again, you can test for primary polycythemia, but I don't do that routinely. Regarding smoking cessation, I think it's a big problem because we don't have, at least in my country, specific measures. We used to have, or there are some, courses and specific meetings for smoking cessation for patients, but I found them not really useful or partially useful. I think still it's an unmet need. We used to have medications which are very partially useful. I don't know, again, in Jamaica, I'd be glad to hear if you have other thoughts for that, but I found smoking as a real problem in patients who cannot quit. And smoking is one of the risk indicators in the TB risk score for secondary prevention, current smoking. And again, it's a residual risk. I see it as a residual risk, of course. What is your thought, Ernest, regarding smoking?
Well, I think we're all in agreement that smoking is a major risk factor for ACS and PAD, for that matter. And but I think our approach, towards smoking has not been the appropriate one. I think smoking is an addiction, really. And until we begin to treat it as an addiction, then we're not going to get any results. I don't think cardiologists were trained to deal with addiction. We recommend to people quit smoking. The recommendation quit smoking is not really the same as exercise, right? Some people may be addicted to exercise, which is not a bad thing, but those who are not addicted could be encouraged to take up exercise. But I think smoking is an addiction, the same way, chronic alcoholism is an addiction and has to be treated as an addiction. And for those people who are smoking, there is a parallel link between the length of time smoked and, quantity smoked. They are all essential in your risk prediction. But I think telling people just quit smoking is not the answer. And I don't know that any medication has been effective in the long term in getting people to stop smoking. But, we continue to encourage people to stop. It's probably easier to encourage people not to smoke than to stop people from smoking.
Yeah, for sure.
Yeah. So let's see if there's one more question. Sorry, Alon, I know it's late where you are.
No, that's fine.
But this has been a very fascinating conversation, and
great, thank you.
People want to hear more. I have a comment that, the next, somebody, we want to hear more, of course. I think you've addressed this question. At what point in the treatment cycle do you add PCSK9 inhibitor? You've already addressed that, so we won't take you back there. LDL cholesterol lowering, the concept of, the lower the better, we push as low as we can, which in the olden days we thought there was a curve, a U curve, but that's slightly disproven. But the LDL cholesterol lowering injections, how much of that are you using in your practice? And how well has it been received globally? I know you're more in a specialized, place, think about this all day, but in the global cardiology space, how much of LDLC lowering injections are out there and being used?
Yeah, so it's increasing, but not to the level I think that we want it to be. Currently, the use of monoclonal antibodies in Israel is we have the health basket, the national health basket. So the health basket dictates that if a patient is tried statins and onazetamib as well and did not reach a level of below 100, so he is eligible for PCSK9 inhibitors as in the health basket. We also have had other insurances that we can cover from 70 milligram per deciliter, meaning that we still have many patients who do not reach the goal with statins and ezetimibe, but are not eligible for PCSK9 inhibitors. For example, if a patient after an ACS comes with an LDL on maximum dose and on statins and ezetimibe and comes with an LDL of 65, for example, I think it's the gray zone. We don't have really much to do because PCSK9 inhibitors, at least in Israel, are not indicated in these levels. Still, I think it's increasing. It's increasing nicely, but still, there are many patients that they have a barrier from the injection issue. And from the time, the 2 weeks intervals. I think with this, inclisiran, for example, the siRNAs, might be promising treatment in that a needle like every 6 months might increase the adherence of patients. But still, we need more data, I think, regarding this therapy, not just for LDL cholesterol reduction, but for reducing cardiovascular outcomes.
All right. On this note, we will, round up the conference. Alon, thank you very much for honoring my invitation and for giving a fantastic, presentation. It has excited our interest, and we've learned a lot, and we appreciate the input. All right, Alon, and good night, everyone. See you again same time next week.